This is the critical moment. You've filed the claim, you've waited, and now you have that appointment notice, the compensation and pension, or CJNP, exam. This is the single most important 30 minutes in your entire VA disability journey, and most veterans walk in completely unprepared, treating it like a normal doctor's visit. That is the fundamental mistake that costs countless veterans the rating they deserve, leaving them frustrated and often feeling betrayed by the system they served. We are not going to let that happen to you. We are going to break down the 8 non-negotiable truths you must internalize and execute before you step back into that examiner's office, transforming your next exam from a gamble into a calculated success. If you skip even one of these steps, you are leaving money, and more importantly, the support you earned, on the table. Let's start with the hard truth, the absolute foundation of this entire process, which is the first essential point. The examiner is not your doctor. They are an evidence collector. You must fundamentally shift your mindset away from the therapeutic relationship you have with your primary care physician. The CINP examiner, whether they are a VA employee or a contracted provider, is not there to treat you. They are not there to sympathize with you. Their singular, laser-focused mission is to gather the necessary evidence required by the VA to complete the Disability Benefits Questionnaire, or DBQ, which is the form that determines your rating. Understanding this difference is paramount. If you walk in expecting a friendly chat about your service history or an empathetic ear for your pain, you will be disappointed, and worse, you will fail to provide the objective information the VA needs. The examiner is checking boxes. They are looking for specific medical criteria that align with the 38 Code of Federal Regulations, the rulebook the VA uses to assign percentages. They are measuring range of motion. They are documenting frequency, severity, and duration. They are looking for the functional impact of your condition, not just the existence of the diagnosis itself. They are assessing your current state of being, comparing it against the medical record, and translating that into the specific language the VA rating specialist needs to see. If you spend 20 minutes talking about how frustrating the VA process has been or how difficult your transition was, those minutes are wasted because that information does not go into the DBQ boxes. The examiner's notes are the transcript of your claim's fate. Every word you utter, every movement you make, every grimace you suppress. It is all data. It is evidence. You must treat this appointment like a deposition, not a consultation. This foundational understanding dictates how you prepare, how you speak, and how you present your symptoms. If you treat them like your doctor, you will rely on them to ask the right questions, and they will not. They are professionals, yes, but they are working for the system, and your job is to give them the precise, undeniable evidence they are required to record. This means your preparation must be meticulous, ensuring you have the exact language ready to describe your limitations, focusing solely on the functional restrictions imposed by your condition. Remember, their loyalty is to the process, not to your individual claim. Your loyalty must be to the evidence. This crucial distinction must be the lens through which you view every subsequent step of this preparation, ensuring that you optimize every interaction to serve the singular goal of accurate and complete evidence collection. This is not a casual meeting. It is a high-stakes evidence session, and you must be the master of your own evidence presentation. Now that we have established the examiner's true role, we move immediately to the second, equally vital, preparation step. You must know the DBQ for your condition better than the examiner does. The disability benefits questionnaire is the blueprint for your claim. It is the form the examiner fills out. It is the form the rater reads. It is the structure of your success. If you go into the exam without having read, studied, and annotated the specific DBQ related to your claimed condition, whether it's for migraines, musculoskeletal pain, PTSD, or GERD, you're flying blind. The DBQ reveals exactly what criteria the VA uses to assign a rating. For a knee claim, the DBQ dictates that the examiner must measure flexion and extension, and it specifies the exact angles that correspond to different rating percentages. If you know the angles, you know what the examiner is looking for. If you know the form, you know the questions they have to ask, and you know the boxes they have to check. Your preparation involves rehearsing the answers that directly populate those boxes. Do not wait for the examiner to lead you. You must lead the examiner to the necessary evidence. This is not about exaggeration. This is about accurate, complete, and regulatory-compliant articulation of your suffering. For example, if the DBQ for a mental health condition asks about occupational and social impairment, you need specific rehearsed examples of how your condition prevents you from maintaining employment or engaging in social activities. If the DBQ asks about frequency of symptoms, you need to state clearly, I experience this level of pain 5 out of 7 days a week, or I have a severe migraine that requires bed rest at least twice a month. Generic answers like, it hurts all the time, are useless to the rater because they do not translate into the specific frequency, severity, or duration required by the rating schedule. The DBQ is your cheat sheet, your roadmap, and your defense. Print it out, highlight the sections. Understand the language. When the examiner asks a question, your answer should be the precise, regulatory-compliant response that fits perfectly into the required DBQ field, leaving no ambiguity for the rater. This mastery of the DBQ allows you to control the narrative and ensure that crucial information is not omitted simply because the examiner was rushed or inexperienced. Remember, the VA rates the symptoms and functional limitations documented on the DBQ, not just the diagnosis itself. Your intimate knowledge of this form is the firewall against an inadequate examination. You are essentially pre-populating the evidence fields with undeniable truth. Moving swiftly into the third critical area, which is where many veterans fail to bridge the gap between their daily reality and the VA's bureaucratic requirements. You must translate your pain into functional limitations. Veterans are often conditioned to minimize pain. We are taught to be tough, to drive on, to suck it up. This stoicism is a death sentence in the CENP exam. The VA does not rate your bravery, it rates your disability. You must actively fight the urge to present as fine. When the examiner asks how you are, the correct answer is not, I'm okay, or I'm managing. The correct answer is a direct, concise summary of your current functional limitation. Instead of saying, my back hurts, you must say, my chronic low back pain prevents me from standing for more than 15 minutes, and I cannot lift more than 10 pounds without sharp, radiating pain that forces me to stop. This is the language of functional limitation. This is the language the VA rates. The core concept here is functional loss. How does your condition impact your ability to work, socialize, care for yourself, and perform activities of daily living? Every symptom you describe must be immediately followed by its corresponding functional consequence. If you have chronic headaches, the functional limitation is not just the pain. It is the fact that you must retreat to a dark room, miss work, and cannot drive safely during an episode. If you have anxiety, the limitation is not just the feeling of dread. It is the inability to attend crowded events, the avoidance of social situations, or the difficulty maintaining stable employment due to panic attacks. When describing pain during a range of motion test, you must clearly state when the pain begins, the point of initial pain, when the movement becomes painful, the point of sustained pain, and when the pain becomes unbearable, the point of maximum limitation. Do not push through the pain just to look tough. Stop the movement immediately when pain begins and articulate clearly, that is the point of painful motion. The VA rates the range of motion before pain begins. If you push past the point of pain, you're documenting a greater range of motion than the VA is allowed to consider, effectively lowering your rating. This requires conscious effort and rehearsal. You must override decades of military conditioning to achieve an accurate assessment. Remember, the examiner is looking for objective evidence of functional loss, and if you minimize your symptoms, you minimize your rating. This translation from subjective pain to objective functional limitation is the cornerstone of a successful high-rating claim, ensuring that the rater understands the true daily impact of your service-connected disability on your quality of life. The difference between "I have pain" and "I have pain that prevents me from ascending stairs without using the railing and pausing every 5 steps" is the difference between a 0% rating and a compensable rating. Let's transition now to the fourth crucial strategy, a deep dive into the concept of the cycle of frequency, severity, and duration, FSD. The VA doesn't just care that you have a condition, they care about how often, how bad, and how long it lasts. This FSD cycle is the quantitative metric that turns subjective feeling into objective evidence. When you describe a symptom, you must immediately quantify it using FSD. This provides the rater with the concrete data points needed to justify a higher percentage. Think of it this way. Frequency is the number of times per week or month. Severity is the intensity, often using a 1 to 10 pain scale, but immediately translating that number into functional impact. And duration is how long the episode lasts, or how long the limitation persists throughout the day. For example, if you claim migraines, simply saying, "I get bad headaches," is useless. Instead, you need to articulate, "I experience prostrating headaches, severity, that require me to lie down in a dark room and miss work, functional impact at least 4 times per month, frequency, and each episode lasts between 12 and 48 hours, duration." This level of detail is non-negotiable. If you are claiming digestive issues, the frequency might be the number of bowel movements per day or week. The severity might be the level of incontinence or pain associated with them, and the duration might be how long you have suffered from this chronic condition. You must prepare a detailed FSD statement for every single claimed condition. Write these down. Practice saying them aloud. They need to roll off your tongue naturally during the exam. The examiner is listening for patterns, for consistency, and for the necessary quantitative data to check those boxes on the DBQ. If your description of frequency is vague, sometimes or often, the rater cannot confidently assign the percentage dictated by the schedule, which often requires specific minimum frequencies, e.g., at least once a month, or more than 4 times per week. The clarity and specificity of your FSD cycle description will directly correlate with the accuracy and fairness of your final rating decision. Do not assume the examiner will probe for this detail. They often won't, especially in a time-constrained environment. It is your responsibility to provide this crucial quantitative information proactively, ensuring the record is complete and robust enough to withstand any scrutiny from the rating specialist. This structured approach prevents the examiner from dismissing your symptoms as intermittent or mild, forcing them to document the true debilitating nature of your daily struggle. Our fifth essential preparation point addresses a common pitfall in complex claims: mastering the connection, secondary conditions, and the nexus statement. Many veterans focus solely on their primary service-connected disability, completely overlooking the domino effect that disability has created in their body. The VA recognizes secondary conditions, medical issues caused or aggravated by an already service-connected disability. This is often where veterans miss out on significant increases in their overall rating. Before your exam, you must rigorously review your medical history and identify every condition that can logically be traced back to your primary issue. Did your service-connected knee injury force you to change your gait, leading to chronic hip and back pain? That hip and back pain is a potential secondary claim. Is your chronic pain leading to severe depression, anxiety, or insomnia? Those mental health issues are potential secondary claims. Did the medications you take for your service-connected pain cause gastrointestinal issues like GERD? That GERD is a potential secondary claim. You must be prepared to articulate this connection, this nexus, during your CENP exam. While the examiner is not required to establish the nexus for you, if you clearly present the evidence, they are obligated to document the connection. When discussing your primary condition, introduce the secondary effect immediately. For instance, my service-connected lumbar spine condition causes such severe chronic pain that I have been unable to exercise for 5 years, resulting in significant weight gain, which has now led to diagnosed obstructive sleep apnea, a secondary condition. By providing this concise narrative, you are prompting the examiner to consider the secondary impact and potentially fill out a secondary DBQ, which dramatically strengthens your overall claim package. This requires a forensic review of your entire medical file, identifying all diagnoses that have arisen since your initial injury or diagnosis. Do not wait for the VA to connect these dots. They rarely do so proactively. You must present the chain of causation clearly and unequivocally. The power of secondary claims lies in their ability to reflect the true, holistic impact of your service injury on your entire system, often pushing your combined rating into higher, more beneficial compensation tiers. Ignoring secondary conditions is akin to leaving the most valuable pieces of evidence out of your own trial. Maximize your claim by meticulously tracing the cascading effects of your service injury throughout your entire physical and mental landscape, ensuring every related diagnosis is documented and attributed correctly. The sixth critical area is often the most challenging and requires immense mental preparation. Handling the mental health CENP, the importance of the worst day. If you are attending a CENP exam for a mental health condition, PTSD, anxiety, depression, etc., the rules of engagement shift slightly, but the core need for functional limitation remains. The examiner will inevitably ask you about your symptoms. Your response must not describe how you feel on an average, managed day. You must describe your symptoms and limitations on your worst day, or at least a recurring bad day within the past month or two. The VA rates the severity of the condition, and if you present as functional and stable, the rating will reflect that stability, not the underlying debilitating episodes. When discussing mental health, veterans often default to minimizing their struggles, saying things like, "I have some trouble sleeping," or "I get anxious sometimes." This is insufficient. Instead, you need to paint a vivid, detailed picture of the functional impairment during a crisis or a severe episode. For example, on my worst days, I experience panic attacks so severe that I cannot leave my bedroom. I am unable to answer the phone, interact with my family, or focus on basic self-care. These episodes occur at least twice a month and last for 24 to 48 hours, resulting in missed work and extreme social isolation. You must discuss the frequency of suicidal ideation, if applicable, using indirect, safe language like thoughts of self-harm or feeling hopeless about the future to adhere to safety guidelines. The impact on your relationships, e.g., strained marriage, inability to maintain friendships, and the occupational impairment, e.g., job instability, difficulty concentrating, memory issues. The mental health DBQ specifically looks for signs of occupational and social impairment. You must provide concrete examples of how your condition has cost you jobs, prevented promotions, or led to social withdrawal. Do not rely on vague descriptions of feelings. Rely on objective, documented behaviors and consequences. This requires rehearsing specific anecdotes that illustrate the severity of your impairment. Furthermore, be prepared for questions about substance use or anger management. Answer honestly, but always link these behaviors back to the service-connected mental health condition as a coping mechanism or symptom. The goal is to show the examiner that your condition is a constant, debilitating force, not a minor inconvenience. Remember, the rating is based on the severity of functional impairment, and the worst days are the truest measure of that severity. Our 7th point focuses on external validation, a crucial element the VA heavily relies on. The power of the buddy letter and lay statements. The VA system operates on documentation. While your medical records are the primary source of evidence, the VA also places significant weight on non-medical evidence, particularly statements from people who know you well. These are called lay statements or buddy letters. You must ensure that multiple, compelling lay statements are submitted before your CG&P exam, and you must be prepared to reference them during the examination. A buddy letter is not just a note saying, "John is a great guy." It must be a specific, detailed account of how the writer has observed your disability affecting you over time, focusing on functional limitations. If your spouse writes a letter, it should detail how your back pain prevents you from playing with your kids, or how your PTSD episodes disrupt your sleep and cause extreme irritability. If a former coworker writes one, it should describe the specific ways your anxiety caused you to miss deadlines or avoid team meetings. These letters serve two vital purposes. First, they corroborate your testimony, proving that your description of symptoms is consistent and observable. Second, they often fill gaps in the medical record, especially for conditions that were difficult to diagnose during service or for symptoms that primarily manifest at home, away from medical observation. When you are in the exam, if the examiner seems skeptical or is moving too quickly, you can gently introduce this external evidence. "Doctor, my wife documented the frequency of these night terrors in her lay statement, which is in my file. She noted that they occur at least 3 times a week, resulting in significant sleep deprivation for both of us." By referencing the lay statements, you are reinforcing your testimony with third-party verification, making it much harder for the examiner to dismiss your claims as subjective exaggeration. Ensure these letters are written by individuals who have witnessed the onset or the progression of the disability, and that they include the author's contact information and relationship to you. The more external, consistent evidence you provide through these powerful lay statements, the more robust and undeniable your claim becomes, significantly improving the likelihood of a favorable DBQ completion. This is the evidence that humanizes your struggle and provides the necessary real-world context the cold medical records often lack. Finally, we address the often overlooked immediate aftermath of the exam, the 8th and final critical step. Post-exam actions, immediate documentation, and requesting the DBQ. Your job is not done when you walk out the door. The moments immediately following the CNP exam are crucial for documenting your experience and preparing for potential appeals. As soon as you leave the facility, ideally while sitting in your car or a nearby quiet spot, write down everything you remember about the exam. This is your immediate post-exam journal entry. Document the examiner's name, the time the exam started and ended, and the exact questions they asked. Most importantly, document your exact answers and any observations the examiner made. Did they only measure range of motion once? Did they seem rushed? Did they cut you off? Did you forget to mention a crucial symptom? This detailed contemporaneous record is your safety net. If the resulting DBQ or rating decision is unfavorable, this journal entry becomes the primary evidence you use to challenge the adequacy of the exam. You can submit a statement arguing that the examiner failed to follow regulatory requirements or that they omitted key information you provided, using your notes as proof. The second crucial post-exam action is immediately requesting a copy of the completed DBQ and the examiner's notes, the medical opinion. You have the right to these records. You can typically request them through a VSO, the VA's Release of Information Office, or via a FOIA request, though often the fastest way is through your VSO. Once you receive the DBQ, meticulously review it against your notes and the actual criteria for your condition. Did the examiner accurately record your range of motion? Did they check the box for functional loss due to pain? Did they correctly document the frequency and severity of your symptoms? If you find discrepancies, and you often will, you can immediately file a rebuttal statement before the VA finalizes the rating decision, potentially saving months or years of appeal time. This proactive review allows you to catch and correct errors while the evidence is fresh, transforming a potentially unfavorable outcome into a successful one simply by holding the examiner accountable to the evidence you presented. Never assume the VA will send you the DBQ. You must actively request it, and your detailed post-exam notes are the key to interpreting and challenging its contents. Let's take a moment to cycle back and reinforce the immense importance of these 8 foundational pillars, because the margin for error in a CONP exam is vanishingly small, and the consequences of failure are profound and long-lasting. We are talking about the difference between receiving the necessary care and compensation for your service-connected injuries and being left to struggle in silence, often for years, while navigating a daunting appeals process. We began with the critical necessity of understanding that the examiner is not your doctor, they are an evidence collector. This means every interaction must be transactional and focused solely on providing regulatory compliant evidence. You are not seeking a diagnosis. You are providing data points that align with the 38 CFR. This mindset shift is the armor that protects you from minimizing your symptoms out of habit or military conditioning. If you treat the exam like a casual visit, the notes will be casual and the rating will be low. You must be precise, professional, and entirely focused on the functional limitations of your condition, treating the examiner as the conduit through which your evidence flows to the rating specialist. The examiner's notes are the only thing that matters, and your job is to ensure those notes are robust, complete, and fully supportive of the highest possible rating. This leads us directly back to knowing the DBQ better than the examiner does. This is not optional, it is mandatory homework. The DBQ is the sacred text of your claim. By studying the DBQ, you preemptively understand the VA's specific criteria for granting a rating. You know that for a sleep apnea claim, they need to know if you require a CPAP machine, and for a heart condition, they need to know your METS level. Your preparation allows you to structure your answers to perfectly fit those DBQ boxes. If you know the questions they must ask, you can ensure they get the accurate, detailed answers they need, even if they rush the process. Mastery of the DBQ is the ultimate act of self-advocacy, ensuring that no technical requirement is missed due to the examiner's oversight or unfamiliarity with the nuances of your specific condition's rating schedule. The third pillar: translating your pain into functional limitations. Must be an ongoing practice. Pain is subjective, limitation is objective. The VA rates the loss of function. You must constantly practice converting your feeling of pain into a concrete description of what that pain prevents you from doing. The phrases, "I can't lift heavy things," or "I have trouble bending over," are weak. The phrases, "I cannot lift more than 10 pounds due to radiating pain," or "I am unable to tie my shoes without severe discomfort and assistance," are strong. They provide measurable, undeniable evidence of functional loss. Furthermore, remember the critical rule during physical exams. Stop movement at the point of pain. Do not push through it. Articulate clearly that the movement is now painful. This is the single biggest error veterans make in musculoskeletal exams, and it directly costs them range of motion percentages. You must prioritize accurate documentation of pain-limited movement over showing off your toughness. We solidified this concept with the fourth pillar, the cycle of frequency, severity, and duration, FSD. Vague descriptions kill claims. Specific quantitative data builds claims. Every claimed symptom must be quantified using FSD. How often does it happen? How debilitating is it? How long does the episode last? This structured approach removes ambiguity and provides the rating specialist with the concrete evidence required by the rating schedule. If the schedule requires symptoms to occur more than 3 times per month, for a certain percentage, your answer must explicitly state that frequency. If you don't provide the numbers, the VA can't give you the rating, even if you deserve it. This FSD quantification is the bridge between your lived experience and the VA's bureaucratic requirements. The fifth strategy: mastering the connection, secondary conditions, and the nexus statement, is the path to maximizing your overall combined rating. Very few service-connected injuries exist in isolation. They are stressors that cascade throughout the body. Your job is to meticulously trace that cascade. Identify every condition, mental, physical, or systemic, that arose or worsened after your service-connected condition was established. Prepare your narrative to clearly explain the causal link. This proactive identification and articulation of secondary conditions ensures that the examiner is prompted to document the full scope of your service injury's impact, preventing significant portions of your disability from being ignored simply because they were not the initial focus of the claim. For those facing mental health reviews, the sixth point remains vital: handling the mental health C&P, the importance of the worst day. The examiner needs to understand the depth of your impairment. If you present as stable and coping, the rating will reflect that stability. You must be honest, descriptive, and focus on the functional limitations experienced during your most severe, recurring episodes. Discuss the impact on your ability to work, your relationships, and your self-care. Use concrete examples of isolation, panic, or avoidance behavior. Do not minimize the severity of symptoms like hypervigilance or chronic irritability. This is not the time for stoicism. It is the time for accurate, detailed disclosure of the functional impairment caused by your condition. The seventh pillar: the power of the buddy letter and lay statements, provides the essential external validation. These statements transform your subjective testimony into corroborated fact. Ensure that these letters are detailed, focused on functional limitations, and submitted before the exam. By having multiple witnesses, spouses, friends, coworkers attest to the observable effects of your disability, you build an undeniable case that reinforces the severity and frequency of your symptoms, filling in the gaps that medical records often leave open, particularly for conditions that wax and wane or manifest primarily outside the clinical setting. Finally, the eighth and concluding action: post-exam actions, immediate documentation, and requesting the DBQ. Is your quality control mechanism. Your immediate notes protect you from inadequate examinations and ensure you have the evidence needed for a successful appeal if the initial decision is unfavorable. By immediately requesting and reviewing the DBQ, you take control of the evidence stream, allowing you to proactively address errors before they become permanent parts of your record. This diligence ensures that the system is held accountable to the evidence you provided. These 8 steps are not merely suggestions, they are the required protocol for navigating the VA C&P system successfully. You must approach this exam not as a passive patient, but as an active, informed participant who controls the evidence presented. Your preparation must be exhaustive, your articulation precise, and your focus unwavering on functional limitation, frequency, severity, and duration. By mastering these principles, you move beyond hoping for a favorable outcome and step into the certainty of a well-documented, meticulously prepared claim that accurately reflects the full extent of the sacrifices you made while serving. Go in prepared, speak the language of the VA, and demand the rating you have earned.